This is the SPSP Paediatrics webinar on worry and concern, with a particular focus on parental care and patient concerns. My name is Sonia Joseph. I'm a consultant paediatrician in Edinburgh. I'm the clinical director for medical specialties there, and I'm also the SPSP Paediatrics lead. Before we go into the main session and the speakers, we've got some little bits of housekeeping. So while the speakers are presenting their talks, your cameras and your microphones will be muted. And when we get to the question and answer sessions, they'll be opened up. But if you as individuals want to raise a hand and ask a question, you'll still need to unmute yourself and open your camera as well. Secondly, we'd really like you to use the chat function. This is being monitored by members of the team, so we can hear your comments and your questions. And the more questions we get, the more interactive the session is, and the more we learn from each other. The session is also being recorded, which means that you can share the link with your colleagues and friends, and as an output of the session there'll be a summary that's sent to all the participants that joined, which will include links to the learning materials and things that we can signpost to you as colleagues, not just for your own clinical teams to provide care, but also to colleagues to help with your learning, and for those who are medical in the call, for your appraisals. It's quite good to put a link in there to these learning materials, and for nursing and colleagues to their KSF framework as well. We've got an active session planned that runs from 12:30 till 2 o'clock. I'm absolutely delighted that we'll have speakers from within our own team in HIS, but we'll also have representatives from New Zealand, from the Starship Hospital, to discuss projects that they've undertaken. And we've got some brilliant local work happening in NHS Lanarkshire that I'd like to share with you. And we're delighted the teams could join us today. In between each speaker, we from New Zealand and from Lanarkshire will have a question and answer session, and then more time to reflect and discuss at the end of the session, and for your teams to give us feedback. Why are we focusing on this? It's been pretty obvious from the media with everything that's been going on with Martha's Law, but also in terms of the SPSP launch and the feedback we've had from colleagues, there's still that nuance, that concern that maybe we're not picking up when families are concerned about their children, because after all, they know their children well. And so the aims of the webinar are to understand the responses to worry and concern in paediatric services in the current context, and I think that's really important, the current cultural context, to explore patient, family and carer concern in relation to the work of the SPSP Paediatric Collaborative, which we launched in September last year, and to share a range of examples of interventions which act on patient, family and carer concern. And what's really important about the examples that we're sharing is it's actually based on the collective will of teams to start these initiatives and to listen. So I'm absolutely delighted that we've got the opportunity to share this work with you all. So in terms of our session, what I'd like to do now is invite Tim, who's our improvement advisor, to tell us about the current climate around worry and concern. Over to you, Tim.
Thank you, Sonia. Thank you for introducing me. For those of you that don't know me, my name is Tim Shearman, and I am an improvement advisor that works on the SPSP Paediatric Programme for Healthcare Improvement Scotland. And I'd like to just take the opportunity to have a special thanks to Amy Wilson and Mark Wilson, who are two physiotherapy students from Queen Margaret University that are on placement with us at the minute, and they have been really instrumental in pulling some of the content of this webinar together. So, I'd particularly like to welcome those of you today who are joining us for the first time and who aren't necessarily part of our SPSP Paediatric Collaborative. Just to bring you up to speed with our team and our work, the SPSP Paediatric Programme runs national Scotland-wide quality improvement programs for paediatric services. And after a period of hibernation, the SPSP Paediatric program was relaunched in September of last year with our Deteriorating Child and Young Person Collaborative. The aim of this collaborative is to reduce harm from deterioration by improving the recognition, response, and review of the deteriorating child and young person. 13 out of 14 of Scotland's territorial health boards are participating in the collaborative, and it involves a series of learning sessions interspersed by action periods where teams from the health boards design and deliver their own local improvement programs. The SPSP Paediatric Learning System sits alongside all of this work, and today's webinar is the second in that series. So this is the driver diagram and change package for that collaborative, and it was co-designed with our colleagues in clinical and quality improvement communities. The building blocks for this driver diagram are the Essentials of Safe Care, which is an evidence-based package of tools and resources to help clinical teams design and deliver safety-focused quality improvement programs. One of the secondary drivers we've identified in the pediatric driver diagram is action on patient, family, and carer concern. And as Sonia has already explained, this is the focus for today's webinar. And we want to focus on the worries and concerns of patients, families, and carers in acute pediatric settings. Specifically, we want to explore how these concerns can be used in the context of recognizing and responding to clinical deterioration in children and young people. So the decision to focus on this topic came about because of ongoing conversations between our team and with colleagues within Scottish Territorial Health Boards, Healthcare Improvement Scotland, and further afield. These conversations, they primarily highlight to us the history, evidence base, wider interest, data, and family voices that support an effort to improve action on patient, family, and carer concern. Firstly, there is a long history of listening to families and carers to improve pediatric care. A Google search can reveal multiple news articles on this topic, including this one, which is over 7 years old, as the big yellow highlight shows there. But the history of it is actually much longer than that. And I actually found this piece of social research, which demonstrates that the interplay between child health and parental concern can be studied all the way back until at least the 19th century. With this this social research here pointing out the child and health concern and parental concern, in England between 1860 and 1910. And secondly, there is now a substantial body of research that demonstrates that the patient, family, and carer concern is often the canary in the coal mine that can detect early signs of deterioration in children and young people. I'll explain more of this evidence as the webinar progresses. Thirdly, there's been significant media coverage of patient, family, and carer concern in healthcare recently. There's also been significant interest from organisations outside the NHS, such as the third sector. So this topic is very much on a lot of people's minds at present. Fourthly, in terms of the data submission we receive as part of the collaborative, the feedback from NHS Scotland boards that this is important to them comes through loud and clear. Many boards are asking about Martha's Rule in England, but beyond that, I think this quote here illustrates what many boards are telling us at the minute. We are finding that parental concerns are documented via a tick box, but not what concerns are or what is done to address it. So we're getting the perception that NHS boards recognise the importance of harnessing patient, family and carer concern and that they are asking for it, but it's a little less clear how that information is then being used to identify or act on deterioration. And finally, we know that parents and carers are still highlighting that they at times feel as though their concerns aren't being heard. This quote, which is from a real mother whose daughter passed away from sepsis, paints that picture better than I can in my own words. It was collected during recent co-design work by the SPSP Acute Adult team when they reached out to and engaged with patients, families and carers. And this quote has been anonymized and pseudonyms have been used. So the output of that co-design work was an updated sepsis and deteriorating patient driver diagram for adults. Feedback from those patients, families and carers on those outputs has helped us to see how they feel about this kind of work. This quote is from that same mother and only further highlights how important this is to them. So I suppose what I'm trying to say is that beyond any other reason, this topic is important because it is important to patients, families and carers. So with that said, it's probably worth examining why all of this history, research, media coverage, data, and family voices are saying this is important. Well, firstly, families and carers can help you to identify deterioration earlier in children. They've been shown to be able to detect the early signs of clinical deterioration in their children well before even expert clinicians. Being able to harness this means that earlier intervention can be taken to address those causes of deterioration. It can also promote better communication between families, parents, and medical staff, reducing miscommunication and complaints, but also helping to empower carers and contribute to shared decision making. All of this can help lead to improved outcomes with interventions which effectively harness the concerns of patients, families, and carers, being shown to reduce adverse events and even length of stay. So it is little wonder that some high-profile developments have occurred in this space quite recently. Perhaps the most well-known of these is Martha's Rule, which is an initiative of NHS England. So in 2021, Martha Mills, who was 13, was admitted to King's College Hospital after injuring her pancreas in a cycling accident. She later developed sepsis and sadly passed away because of this. Martha's mother had informed 3 consultants of the family's worries, however was told that her daughter would be fine. An inquest found that with better care, Martha could have survived. So NHS England have therefore introduced Martha's Rule in April 2024. Initially, this was portrayed in the media as a right to a second opinion, but Martha's Rule is actually a fair bit more specific than that, and it's made up of 3 main components. Firstly, that all NHS staff should have access to a 24/7 rapid review team to raise concerns regarding a child's deterioration. Secondly, that all patients, families and carers have access to the 24/7 rapid review team to raise concerns regarding their child's deterioration. And thirdly, that there is a structured approach to obtain information from patients and families daily. In Scotland, there is currently no update that I can give on the adoption of Martha's Rule, but we will be following how it develops in Scotland and taking note for our programme. In the meantime, it might be helpful to reflect on the provisions of Martha's Rule in Scotland. With respect to parts 1 and 2, we do know that there is variation among boards in how they provide rapid reviews for their patients. With respect to part 3, the Scottish National Pews requires that parental concerns are recorded each time observations are taken. Today, we're going to hear of an international example that addresses point number 2 from Martha's Rule and a Scottish example of work being undertaken to understand when parental concerns are gathered and how these concerns are then acted upon. But beyond Martha's Rule, there are a lot of other important institutions with a stake in this area. There are many third sector organisations pushing for better management of parent, carer and patient concerns in acute hospital settings. Both the Florence Nightingale Trust and the Patients Association are key stakeholders in some of this work, for example in the NHS England Worry and Concern Collaborative. This national piece of work in England has commissioned 7 pilot sites to provoke 2 changes. Firstly, to incorporate patient worry and concern into early warning and diagnostic tools. And secondly, to contribute to a shift in culture and practice that empowers patients, families and carers to escalate concern around deterioration and clinicians to listen to and communicate more effectively about these matters. And if we want to look further afield than the UK, it is worth calling out the work of Cincinnati Children's Hospital, which has for years developed and deployed a range of interventions intended to achieve that shift in culture and practice. Some of their interventions include family-centred ward rounds or the child risk dialogue. So in a similar vein to Cincinnati Children's Hospital, both the HSE in Ireland and NHS England have introduced structured approaches for staff and families to discuss their concerns. This initiative from Ireland seeks to clearly state the steps for escalation to parents, while the example from England provides staff with guidance on how to effectively gather and understand parental concerns, as well as how to escalate them appropriately. I suppose initiatives like this emphasize the staff pathway for escalating concerns once those concerns have been gathered and listened to effectively. Other interventions, such as calling for help from Western Australia or Ryan's Rule from Queensland, also in Australia, gives families a more active role in escalating their concerns should they not be resolved by staff escalation. Most of these interventions prompt families to raise their concern with the treating doctor or nurse first, followed by progressively contacting sequential layers of health professionals. Many of these interventions end by providing families with a mechanism to request a rapid review from a clinical review team, usually by way of a designated phone number. One thing I'd like to point out is that these interventions take considerable time to design and to implement. But initial tests of change in this space don't have to start out as such big pieces of work. In Scotland, as I said, we've already got that mechanism to regularly gather parental concern during PEWS observations. So your teams might want to start here to understand whether parental concerns are being accurately collected at this point, what happens to them after this point, and whether parents feel empowered by these conversations before moving on to more system-wide responses like these. It is also important that I point out that these interventions have an extensive evidence base behind them. Fox et al. From 2023 found that rapid response interventions help to increase awareness of who, when, and how to escalate, and help to form better partnerships between family and clinicians. Dwyer et al. In 2020 found that their intervention, Ryan's Rule, improved communication, enhanced their understanding of health plans, provided access for voicing concerns, and ultimately alleviated apprehensions around deterioration. And of course, it is worth pointing out again that this is an area that is garnering more and more interest. This quote, which is from NHS Grampian paediatrician and college president of the RCPCH, Steve Turner, highlights how all this evidence has built to the point that we now know working on this is the right thing to do. I'm just going to pause there so everyone has an opportunity to read the quote. Great. So, what to do with all this information? Well, what I'm about to say really goes for our SPSP Paediatric Collaborative members. So if you're joining us from outside the collaborative, please just take this as a learning opportunity. But for our collaborative members, it might help to tie it all back to the quality improvement journey. Firstly, we just want you to listen to our guest presenters on this webinar. Not every intervention is going to be right for every setting, so listen and take notes and think about the relevance to your area. Then take these thoughts to your team meetings and discuss them. If you're a member of your board's SPSP Paediatric Collaborative team, then maybe you can put your learning to immediate use. We know that some boards are still doing work to understand their system, so perhaps you could do some work to understand how parental, carer, and patient concern is handled in your area. Or perhaps you've already done that work and now you want to develop a local aim around parental concern. For example, aiming that 100% of all parental concerns documented on PEWS are handled appropriately. Or perhaps you have your aim and now you're just looking for some change ideas to test. In which case, you might hear something today that makes it easier for you to decide which change idea is right for your area. If you are doing or are planning to do some work in this space, then please share that work on our collaborative teams channel so that other teams can learn from what you have done. So thank you for your time, and I'm going to pass back over to Sonia.
Thanks very much, Tim. That was an excellent summary of where we are and the current cultural context. Really appreciate that. Unfortunately, we've had some technical difficulties. And so Jess Hart, who had hoped to join us live, isn't able to at present. So what we're going to do is that we're going to run a recording that she'd previously done for us and then take things from there. So over to the recording. Thank you.
Jess. I work at Starship Children's Hospital for the patient at risk team as their nurse consultant. And I'm going to give you a little presentation on Kōrero mai at Starship. So Kōrero mai, which is Māori for talk to me, this pathway was established at Starship with the aim to facilitate parental and patient concerns to the medical and nursing teams. It provides families and whānau a clear direction of how to call for help when they're concerned about their child's clinical condition. It recognises that it can be difficult for parents to communicate their concerns to healthcare teams and for staff to understand just how worried they're feeling about the changes in their child's condition. Kōrero mai is a ward-based escalation tool, and by that I mean it wasn't rolled out in PICU or in ED. And as such, the project was led by and continues to be championed by the patient at risk team at Starship, as this fits nicely under their at-risk patient umbrella. And just to provide a little Kiwi education, the Māori word whānau means family. It is not a word that's exclusive to Māori families. However, when used with Māori families, the word whānau means the entire family, including extended family members. So the objectives of this presentation is to share the work we're doing here at Starship with you, to explain how the project was rolled out, and to describe how the pathway works, and update you on where we're at with the service today. So before I start, I'd like to provide a little demographic of the healthcare system in New Zealand. In 2022, the district health boards were disbanded and replaced by Te Whatu Ora, or Health New Zealand. Services were to be nationally planned and regionally managed to suit local needs. There are several hospitals spread out over the country. Majority of those are in the North Island, where the largest population is. This image on the right doesn't account for the private hospitals in New Zealand. We have 88 publicly funded hospitals, and of those, we have 19 large facilities and just one National Children's Hospital, which has 170 beds. In Auckland, Starship's trust equivalent is Te Tukutumai, or Auckland City Hospital, and we share a campus with an 800 inpatient bed adult hospital. A reasonable amount of the large tertiary hospitals in New Zealand have a PAR service, or a patient at risk service, and this is only for adult patients. At Starship, we're the only PAR service that see children in New Zealand. The PAR role is part of the mandatory escalation process for PEWs. They respond to all codes, they review patients with PEWs breaches or clinical concerns, they perform active rounding to identify at-risk patients. The structure of PAR and Starship is quite different to the adult service, and that's just because of the nature of the skill set the PAR nurses need, and the knowledge of PICU admission criteria is essential. PAR are governed by PICU and they report to the nurse unit manager. We also have an SMO lead who is a PICU intensivist and is able to devote 0.3 of her FTE to PAR. We have a full-time charge nurse, full-time nurse educator, and a 0.6 FTE nurse consultant, which is myself, and 14 nurse specialists. These nurse specialists all work part-time for PAR and part-time in PICU. Now, Kōrero mai was work that was led by the Health Quality and Safety Commission's 5-year deteriorating patient program. On this slide, you can see a snip from the Health Quality and Safety Commission's website, and here you can look at their PEWs work streams, and from there they have guidance on co-designing a Kōrero mai service. So now I'll discuss how it began at Starship, and this is information that was shared with me by Wendy Sullivan, who was a lead in this project at Starship, as she was the patient at risk charge nurse at the time. A project work group was set up to introduce Kōrero mai to Starship, and we were lucky enough to have the influence of the Starship Medical Clinical Director as project sponsor. The working group was comprised of those listed there, and they brought a variety of key skills to the group. They looked at the experiences of other hospitals around New Zealand who had already introduced Kōrero mai and decided on how those learnings could be applied to our mokopuna, or children, and our whānau, or families, at Starship. Family-centred care is our philosophy at Starship, and it stresses the importance of hearing the experience of healthcare for whānau. On a case review of children cared for in Starship in the 12 months leading up to this project, families and whānau often expressed concern about their child's deteriorating condition. Breakdown of communication is between whānau and teams was sometimes identified as a problem. Whānau know their children best, they observe those subtle signs of change, and they're invariably accurate when it comes to recognising that their child isn't right. Developing the pathway was a 2-year journey. Multiple teams were involved, and And as I'm sure you guys all experienced during COVID in 2020, there was a significant amount of change across the organisation. So we took advantage and were encouraged to take advantage of that momentum for change. So in other words, things were actioned a lot quicker than they probably normally would have been. The benefit of this time frame in New Zealand was that inpatient numbers were reduced. There were cancelled electives. We weren't experiencing the usual winter workload demands for patient care due to lockdown. You know, children weren't in daycare, they weren't going to school. So this resulted in that luxury of time, which could be used for education, which is, you know, I'm sure, as you all know, it does not come along very often. So the Kōrero Mai project was focused on the Starship wards, emergency department, PICU, NICU, the child family unit, which is our mental health unit. These were all excluded. However, we're hoping to implement this in the emergency department soon and to include it into their discharge process, planning process in PICU. So Kōrero Mai embodies the principles of Speak Out for Safety and medical mediation programs of active listening, acknowledgement of feelings, and a shared understanding of what's going on for the family. And I just wanted to show you here our Speak Out for Safety ID cards that these staff carry. It uses a graded approach and common language, enabling staff concerns to be escalated and ensuring concerns are listened to and responded to. So this is the Kōrero Mai three-step pathway. And what it does is it formalises work as done by teams every day, checking in with the child and family, answering questions, talking through the plans of care. We developed an escalation pathway for families and a response pathway for staff, or kaimahi. And that ensures that senior nursing, medical and allied health staff are informed of the family's concerns and are involved in resolving the concerns. So you see here on the left, the family 3 steps. 1, talk to your nurse. 2, talk to the nurse in charge. 3, talk to the Code Pink team or the rapid response team. And on the right-hand side, the kaimahi at each step, the staff member will acknowledge and explore the young person, parent or whānau concern. They will assess and review that child's condition. They will escalate care to the RMO or SMO and senior nursing staff. They will share decision-making with the young person, parent or whānau, and they'll check back in with them to ensure that their concern is resolved or that the child is physiologically stable. So this is a Kōrero Mai poster. It should be visible in every parent, every patient room and in the parent kitchens. Down the bottom here, these spaces are completed to provide the caller with a script of what to say if they make a Kōrero Mai call. The family information brochure is included in the welcome pack that all families receive when they're admitted to an inpatient ward at Starship. And down the bottom it has a QR code which links to the Kōrero Mai video on the Starship website. And when the parent or caregiver looks at the Starship website, they find the video about Kōrero Mai. And this is just a picture of what you'll see on the website. So this is the pathway linking the actions of the caregiver or whānau to the required actions of staff. And I'm going to break this down over the next couple of slides. So step number 1, talk to the nurse. And the nurses are already doing a lot of these steps. Using closed loop communication is really important in this step. Step number 2, ask to speak to the nurse in charge. This is similar to step number 1, but involves more senior members of the team. And you can see the escalation up to the senior staff is a little bit more actioned, a little bit quicker in step number 2. Step number 3, an 800 number was set up to make for families to make a Code Pink call, free of charge from the child's bed space. A Code Pink call at Starship is similar to like a MET call or a rapid response call. And a Code Pink, the PAR nurse, the med reg, the PICU reg, the CNM, and the duty manager are paged. The team have then 15 minutes to respond, which is different to a Code Blue, which is life-threatening, and that would add in the emergency department registrar to that group who are paged. So different hospitals have chosen different methods of what to do with this phone call. In Auckland City Hospital, for example, this call goes straight to the PAR nurse specialist. In some other hospitals around Auckland, the call goes to the clinical nurse manager or the duty manager. At Starship, it was a conscious decision to make it a code call And this is to avoid any potential bias of the core recipient. You wouldn't want people not attending due to prioritising other tasks just because it's a kōrero mai call. You risk people making assumptions it's going to be a communication-based call. And more importantly, it ensures you have the right people looking at the patient at the same time and making a plan. So on reflection, what worked well with Kōrero mai at Starship? One of the key successes of the project was the multidisciplinary makeup of the project group. The voices of the social workers, Kaya Te Whai, which is the Māori liaison group, they were invaluable for the project team to really understand the vulnerability of some of the family members and their inability to feel safe to speak out when they're concerned about their child's condition. Another key success was having 2 nurses, which was a 1.2 FTE. They had dedicated time to commit to the project, and that was really vital to the rollout of Kōrero mai in that time frame. The Douglas Starship SIM team worked tirelessly to ensure a variety of education sessions were available to all board and non-clinical staff. And the involvement of those members of the 24/7 team, that was really valuable, as a lot of support is given to families and ward staff in the after hour time. The time utilised on Kōrero mai calls is roughly the same as most co-pinks, so anywhere from 45 minutes to 1 hour. They utilise the same skill set and escalating to people who can perhaps give more answers or give different perspectives. And if those calls are non-clinical in nature, then you could argue that this is actually time well spent negating a potential complaint. So where are we at now, 4 years on after implementation of Kōrero mai at Starship? Well, we have pretty low numbers of Kōrero mai. For example, in 2023, there were 6 calls the entire year. So this suggests that either steps 1 and 2 are working brilliantly, or perhaps that the service is actually underused because people don't really know about it. The PAR database and case reviews undertaken by the PAR team have exhibited that despite documented parental concern, either in the Pew's chart or in the notes, escalation has not been enacted. And since COVID, we've had a huge turnover of staff, and it begs the question of how well embedded is Kōrero mai into nursing practice now. So dutifully, it seems like a great time to repeat a PDSA cycle. So this is currently underway, and it's being led by myself and the PAR charge nurse, Zach Burton. To find out how some of the information gathering we're doing is finding out how the adult services are going with their Kōrero mai. Myself and the PAR nurse educator went out to some other hospitals around Auckland that had established Kōrero mai back in 2018, just to see where they're at, what their statistics look like, if they've adapted their structure at all. At Starship, I have audited poster placement and compliance to this on each ward. I'm currently in the process of wrapping up interviewing both staff and parents on their knowledge of Kōrero mai at Starship. And in regards to the resources, we feel that the posters and the patient rooms aren't quite eye-catching enough, and they could do with some more plain language for whānau to understand what do we mean when we're saying clinical concern. So this information gathered will help us target our education refresh to those gaps identified versus just doing a blanket refresh of Kōrero mai. I think this will have significantly more impact to embedding it back into our practice. Next steps, of course, are engage with the emergency department to identify when's the right time for them to be using Kōrero mai, and discuss with PICU about the discharge process, including Kōrero mai, to assist in that transition out of ICU. That's a really delicate thing to navigate, because the delivery of this message needs to assure parents they're still in really safe hands when they go to the ward. So when I've been interviewing nurses about their understanding of Kōrero mai, it became quite clear to me that there were some misconceptions about its purpose. One of these is that the Kōrero mai is just about when the parents aren't happy or want to complain about something, or that it's about miscommunication. For instance, they didn't understand the ward round or the plan and they're getting upset about that. The majority of nurses that I interviewed think that Kōrero mai used by parents is for communication breakdowns. And to be fair, a lot of the parental concerns are about that. However, the most important message I'm stressing about understanding Kōrero mai's purpose is that subtle clinical deterioration, the parents will be noticing it early, but they may not be able to articulate. And that's when we should be listening, and we should be putting up our red flag for concern and taking their worry quite seriously. Something that came through strongly from the nurses at that that the agreement is that the parent does know their child best, and the parent will recognise those subtle signs of change earlier. So I use the example. So you've just been with the patient, and after you leave the room, the mum notices that his breathing is a little bit funny. But you don't need to go back into that room for another 2 hours because he's not doing any medications or observations until then. So then when you do go back into the room 2 hours later and you notice his breathing has changed and you're quite concerned, wouldn't you rather have known that 2 hours ago that his breathing had changed? And that's just a really important message that I'm trying to tell the nurses when I provide that on the spot education. Another thing I've noticed is that some nurses think introducing Kōrero Mai on admission is sufficient, and that after this introduction, the parents know they can use it anytime they want. But the reality, as we know, is that vulnerable parents likely won't reach out. They may assume that the nurse already knows what's wrong, or they may have language barriers and not actually know how to express their concerns. What we want is for nurses to be asking the whānau member at each interaction they have about any concerns, using plain language to ascertain if there's anything new they're worried about. And I think as health professionals, we readily check in with parents of children with cognitive impairments or complex needs. And ironically, these are the parents who are potentially more likely to have better health literacy due to their exposure to the healthcare system, and they're probably more likely to speak up than someone who perhaps is their first time in hospital. And lastly, I just wanted to show you the National Pews chart in New Zealand captures parental concern as a non-scoring element. However, the importance of this trigger is emphasised in the text placed above the mandatory escalation pathway, and it can be used as a reason for clinical escalation irrespective of the aggregate pews. From the case reviews that Pa look into, we have identified this as a gap in our practice, and the whānau concern or clinical concern doesn't appear to trump the pews in actual practice. We find charts that will often have no written in the whānau concern box, yet the nursing or physician notes will comment on the parent being worried. And a low scoring pews appears to be a barrier to nurses escalating concerns. So in doing this PDSA, we've identified that that there needs to be a big education drive, which is currently underway by adapting our recognition and response study day to focus on that early escalation a bit more. And the PA nurse educators engaging with the wards opportunistically. And that's the end of my presentation. If you have any questions, if you'd like to follow up anything, please feel free to email me and I'll endeavour to get back to you.
So I'm delighted that Jess was so organised. She'd done a pre-recording, which is fantastic. And I understand that Jess has now managed to join the call for the Q&A. Is that right, Jess?
Hi, yes, I'm here.
Yeah. So we've got some fantastic questions for you. That was an outstanding presentation, and thank you so much for your dedication and continuing to try to join, and also staying up close to midnight to link with our teams. We really appreciate it. What I was going to do is go to some of the fantastic questions in the chat first of all, and if anyone then afterwards wants to raise their hand, I'll then come to you so that you can turn on your camera and your mic and then ask the question directly. But Tim, do you want to just pull out 2 of the questions from the chat, please?
Sure, absolutely. So I think there's a couple of questions from earlier on that sort of got they were covered later on in your presentation, Jess. So I'll start with one question from Helen, who's asked whether or not New Zealand used social media to inform families of the project.
No, during the initial rollout, it was just very much during the admission process. It wasn't advertised via social media, no.
Okay. And I might pull out another one, which is about Kōrero Mai in some of the smaller hospital settings, because you mentioned the setting of New Zealand and the fact that Starship is the tertiary children's hospital. And I suppose there was just a question around how in the smaller district general hospital settings where there might only be one paediatric team, how it works, and if there's any examples where external hospitals or boards are called at that sort of level 3 stage.
So Starship's the only hospital where PA will see paediatric patients, and Kōrero Mai is not in the more district hospitals around the country that have the paediatric patients. It's not really in place for paediatric patients at all. It's very much a PA or a duty manager response service or PICU outreach service, and Starship are the only ones doing this for paediatric patients.
Okay. Sonia, have we got time for one more question from the chat? Excellent.
Yeah, absolutely.
I'm just going to take a question from Laura Fraser. Are most of the calls clinical concern, and do they usually lead to PICU admission, or are the majority manageable on the ward? Have you been able to show sort of patient management improvement with that as well?
Well, that's a really good question. But as I said, we've got extremely low numbers, which is what is kind of driven us to do a PDSA and revive it, and attempt to try and revive it. And we've had 2 my calls last year end up in ICU. But no, the majority of them are communication based. Was that the question?
Yeah, that's great.
Yeah.
Would anyone like to put their hands up and ask a question and come on the call?
I did see something here where someone asked, does the poster become wallpaper or something along those lines?
Yeah, that was Helen who's got her camera open.
Resoundingly, yes, it does.
Yeah,
it absolutely does. And
yeah, and I wondered if you changed them round about, Jess, if you moved things round about. And we tried it a long time ago, and we thought we'd been really clever and put lots of, if you're worried about your child, speak to nurse in charge. And actually, when we pointed them out, people weren't seeing them because they were up for so long, and we had to change it about, and it's how we do that. And that's why I asked the social media question as well. So it's interesting about how we keep that going, about keeping that information going as part of the culture for parents and families, because they do feel very vulnerable. We've observed that you'll do a ward round and a doctor will go in and speak to a family and ask if they have any concerns, and they'll all shake their heads. And then 5 minutes later, a nurse goes in and they've got 25 questions for the nurse. So it's about how we can encourage people to do read back and say, tell me what I've said to you, do you understand, and what concerns have you got? But people do feel very vulnerable in that situation. So it's how we go over that and allow a communication between the nurses with the questions and back to the doctor. But people don't feel they can ask for some reason. Medics must be very scary, but they don't seem to be able to do that.
Yeah, that's really valid, and a big part of the education drive from this is to encourage the nurses to be inquiring at every interaction about any concern that they have since the last conversation they had with them.
That's great, Jess. Thank you.
Thank you, Jess. I can see that there's a question from Dan Houghton. Dan, do you want to put your camera on and your mic on?
Hi, Sonia, can you hear me? So it's kind of picking up what Helen was saying there, and I suppose it's the difference between asking people to speak up or encouraging people to listen properly or listen well or listen better. Because I think there is a growing evidence, and we see this, I've seen it from some simulation work, where we ask staff continually to speak up and shout out their concerns. But we know how hard it is for people of a junior nature to speak up against the power gradient. And I imagine that parents feel the same. And I like, along the lines of what Helen is saying there, is that we put these posters up and we put these things up about Ryan's rule, like that's what my experience was from Australia. And they were all about telling the individual at the bottom of the chain to speak up. And I think that is important, and I think that's part of the solution. But it was lovely to hear from the New Zealand example how exactly as you're saying there about the education is about helping the nursing staff to listen well and getting to that point. Because I know that I've definitely done ward rounds where I've asked, have you got any concerns? And the parents will say, no, fine. but then they'll ask the nurse 20 questions later on. So I was just interested if they could share any more about what they have found around that education piece, what works, what doesn't work in terms of getting staff on board with that idea of changing how they listen to parents.
Yeah, I mean, that's part of what I'm trying to figure out now. We haven't quite nailed down exactly how we want to deliver the education, but certainly when I've been doing the information gathering, I've been educating like on the spot, because what came out quite screamingly to me was that the parent gives me a concern and I reassure them, and not so much I'll hear the concern and assess the child in a head to toe fashion, and that's what I want them to be doing. And I'll review their chart and I'll look at, you know, whatever it is. If, for example, it's about their breathing, I'll do a focused respiratory assessment. Not, yeah, we know he has a respiratory disease and that's why he's here and we'll take good care of him. Like, that's not what it necessarily, that's just the reassurance isn't resolving the concern that the parent's been brave enough to speak up. And your job now is to do a clinical assessment. And I think that piece that's come out, yeah, that was actually a little bit of a surprise. It was and it was not a surprise, because we've had a massive turnover of staff over the last couple of years, and we are sitting quite junior. So I think that senior nursing education downwards is not really happening at the moment.
That's really helpful, Jess, because actually your experience with regards to turnover of staff, you're not alone in that. I'm sure all the paediatricians and the nurses on the call recognise that when you come in shift, there's lots of colleagues that have either retired or moved on, and it's about just starting at ground zero and just sort of re-educating ourselves. And I really like that point about it's not just empathy, it's empathy with action. It's you've raised concerns about your child's breathing. I'm going to assess your child's breathing and revisit things. There's a really good point from Linda Clarihew, thank you, who's a paediatrician in Tayside, who was the original lead for the SPSP and developed the Scottish Pews, and that she said the experience of New Zealand is parallel to other centres around the world. An initial test in Cincinnati only had 8 calls in the first year or two, so that's interesting. And there was a question from Barry Johnson saying, is there any value in having the parents' concern being a scoring mark on pews? Is that something that your team had considered, Jess?
Well, given that it's a national pews, it's a little bit tricky to just change that. It's something we talk about at length, that it should be a scoring element. And we've tried to, you know, like similar to the style you guys have, where the parental concern or the clinical concern by the nurse should trump the pews score. And it doesn't appear to, certainly, and it doesn't in practicality. We know that it doesn't, and pews being a low number is absolutely a confounding barrier to people escalating, and so I'm not sure we're going to be in a position to make it a scoring element anytime soon, but certainly a big education driver around it being something that should make you pay more attention than the number of the pews.
That's excellent. That's really, really helpful. Thank you so much to all of you for your questions and active engagement. Thank you so much to Jess for her persistence in trying to join for the Q&A. It's absolutely fantastic, and it's just brilliant to hear all the work that you've undertaken and to have your time and expertise. I don't know if you're going to, I think it's probably your bedtime, Jess, so I suspect you're going to sign off the call. I want to thank you for your persistence again, and if you've got any further questions, all the colleagues that are on the call, please put them in the chat. We're going to collate them all and send them to Jess for feedback, and as part of the post-webinar review, you'll get a summary of the queries and the answers from Jess and the team, and then you can use that and disseminate it amongst your own clinical teams. I'm now going to move on, if that's okay, just in the interest of time, we're absolutely delighted to have Anne Campbell, and she is a senior charge nurse in paediatrics at Wishaw General Hospital in NHS Lanarkshire, and she's going to share some of the work that the team have been doing locally in a Scottish context on safe transfer of care. Over to Annie.
On mute, not a good start. Can everyone see that okay? Yes, Sonia. So hi everyone, I'm Anne Campbell. I'm the Senior Charge Nurse for Paediatrics at Wishaw General, and I'm just going to discuss a wee bit about our early work on safe transfer of care with a focus on parental concern. So just to give you some background, and first of all in NHS Lanarkshire, and then I'll just discuss our aim and our change ideas and our next steps. So just for anyone that doesn't know NHS Lanarkshire, our paediatric unit is a district general hospital based at University Hospital Wishaw, and NHS Lanarkshire sits between Glasgow and Edinburgh and covers both North and South Lanarkshire, and that extends quite far down to the Scottish borders. So our referral patients come from sometimes quite some distance away. Our population total is currently about 664,000, and approximately 10% of that population is our under 16s that we'll be dealing with at Lanarkshire. So just for some background information, Lanarkshire historically is quite an industrial area, and it's quite a mixed demographic. There's pockets of wealth, but there's also some areas of quite high deprivation and poverty. And as I said before, NHS Lanarkshire is made up of 3 main hospital sites, which is University Monklands, University Hospital Hairmyres, and here at Wishaw. And there's also some small community and cottage hospitals dotted about that area. So we've got one site for paediatrics, which is based here, and we take referrals really from all 3 ED sites, from GPs across Lanarkshire, health visiting teams, out of hours, and as well as patients who've got direct open access, so that would be complex patients or patients that are known to us. All our patients that are seen on both wards have got 48-hour open access, which means for the next 48 hours they can phone at any time for advice, or they can return to be seen if they've got any concerns. So here at Wishaw, we've got 2 wards. So we've got a 24-bed inpatient ward, which covers specialties ranging medical, surgical, ortho, ENT, and mental health. And we've seen a total of 2,757 patients through the ward last year. And then we have Ward 19, which is where I'm based, and that's a 16-bed assessment ward. And we also have quite a high turnover of day patients. So we see patients for bloods, investigations, Botox, day surgery, and medical reviews. Most of our clinics are nurse-led clinics, and through assessment through Ward 19 last year, we've seen 7,238 patients. And as you can see, that's quite a high turnover compared to actually what transpires into transfers in Ward 20. And through day patients, we've seen 4,000 patients last year. We have a staff of 54, which is made up of myself and another senior charge nurse. We've got 6 band 6s, sorry, 7, just one joined us, and we've got the rest made up of band 5 and 6, 12 clinical support workers. So we've got quite a large staff. But in relation to the current work we've been focusing on is the aim, which was decided collectively as a team, that 90% of children will experience a safe transfer of care between paediatric wards 19 and Ward 20 by March 2025. And that's aligned with our Scottish Patient Safety Collaborative on deteriorating child. And really, we met as a unit and a team to discuss how we could achieve this aim. And we've completed our driver diagram here. So we've identified 3 main areas that we need to ensure, which are to standardise our handover documentation. So we did have an SBAR document in place, but that was needing quite a lot of update. And we also want to provide care that's assured through audit and to ensure that we've got effective communication. So not only communication between staff, but also between families, parents and patients. So that tied in quite a lot to the work that we're doing on parental concern. So some of the change ideas that we've had recently were to review our SBAR transfer document. We've also displayed our quality improvement work in visible places within the ward to visually promote our ideas and celebrate our successes. We've undertaken buzz education sessions for all staff to inform staff on why we're wanting to focus on improving safe transfer and how they can be involved. And as Jess was saying, we've also had quite a high turnover of staff, and I'm sure other areas will be experiencing the same, that we've got quite a high group of junior staff. So we're really trying to drill down into them about communication and what the difference really is between parental concern, parental anxiety, and how we can kind of safely raise those concerns. So we've also got a group of staff champions who have been talking about safe transfer and parental concern at handovers, at safety briefs, really any opportunity they can, and just to remind staff of ensuring parents are involved in the handover process. We've also displayed QR codes in our discharge information to try and promote feedback via our care opinion website. And our SBAR handover has been the main way that we're measuring our aim of ensuring a safe transfer. So some of our outcome measures are that our documents signed by both wards. We've included a checklist for pre and post handover, but our recent focus has been on the box in the top right hand side, which is our parental concerns. So what we're finding is parental concerns are documented within PUs. They're occasionally documented within our notes, but there's not really a formal process for how concerns are escalated. So within Wishaw, and I'm sure many of you at District Generals will have the same understanding, that we don't have a large group of staff to call on. So our parental concerns generally are escalated to nursing staff, who would then escalate to medical staff if they're concerned. But really we want to look at any formal escalation policies and how we can go about this. So after trialling several versions of our handover document, we've had it look and improved and added in these 3 questions, just as a visual reminder to ensure better communication in regard to parental concerns. So we do provide care up to the point of deterioration when a patient would require transfer, but what we're hoping is that we're hoping to determine what formal escalation processes we can implement, so that we're catching things before that stage and that we're really picking up on those concerns from patients. So first of all, really what we've done is, we've had a wee look at what is concerning the parent. So we've not got any formal feedback from parents, so we developed a feedback, and it's just a short 3-question survey. Again, this is all very early work, so we're just at the stage of kind of looking at our system and finding out and getting feedback. But we're asking parents to complete this survey after they've been transferred from Ward 19 to Ward 20. And there's just a wee QR code. They can scan that with their phone. It's very easy. We're just in the process of displaying that at each bedside as well, but we're doing that after the transfer, just so that initial, they are kind of eased into the ward, that their concerns hopefully have had time to be addressed at that point. So what we're asking is that if they were informed of the plan of care for their child, how would they rate their experience, and if they've had any questions or concerns, were these addressed or have they been escalated? So initial results have been quite encouraging, in the main that we provide care that parents feel they are informed about, but of course there's always room for improvement. So some of the feedback we've received so far has been really insightful. So again, sometimes it is just about communication, and it is sometimes about the breakdown in communication, but we're hoping to expand on this and look at the feedback over time and find out and draw out any themes from that. So parents are asking, they're wanting an explanation of why they're in Ward 19, why their child's been assessed, about the length of time that it's taken for assessment, and that they've not took much in at the time because they've been so worried. And the third question is if they've had any concerns or questions, do they feel they've been addressed or escalated? So 85% have responded so far that yes, they have been, but again, 14% have responded no. So we're actually in the process of just changing this forum because we feel we weren't getting enough effective feedback about why their concerns weren't escalated. On top of that, we also do feedback from, we do walk rounds from myself and some of the improvement team. So they go speak to parents to make ourselves more visible and reassure parents that it is okay to speak up and raise concerns. I noticed somebody's had commented in the chat there about do we involve the parents in the handover process? So that's part of our change process as well. So we're looking at the process of how patients are handed over and that process between staff and parents. So we're trying to do that handover at the bedside, involve them in the process, ask them at the time, has everything been handed over? Do you feel you've got any other concerns? So from the feedback we've gathered, there is a strong theme around communication between staff and parents. And I feel that if we focus on fostering an environment which is open and welcoming, and we welcome communication and feedback from families, that will create a safe place for concerns to be raised and that will improve our outcomes for our children and young people. So our steps are to continue to review our feedback and explore themes raised, and really then look at how we can formalise the process for raising parental concern. We're planning to look at a patient-parent focus group, and as I've said earlier, our work's very much in the beginning, so we're seeking a better understanding of our system, but happy to answer any questions or queries, and thank you for listening.
Annie, that's absolutely fantastic. Thank you so much. I love your honesty about where you are, the cultural context around and the workforce context. It's brilliant, and it just shows, to me anyway, just what can be achieved with collective will of teams who recognise there's an issue and want to try and find a way to respond to it. So it's brilliant work. Well done. I was going to go over to Tim, if that's okay, just to ask some questions from the chat to you, Annie. And then if anyone wants to put their hands up afterwards, that's great. So Tim, over to you.
Sure, Annie. The first question is, and I'll link these two together actually, how many transfers are there a year between your two wards? And is this something you're looking at when you're transferring children to tertiary centres as well?
So firstly, just the figures are there that we transferred 2,000 odd patients last year. So we see a high number in Ward 19. They're there for assessment, and the patients are either discharged home with worsening advice or they're admitted to the ward. So that figure of 2,000, I can't remember how much there, is how many transfers there are. So we've just started gathering data. We've just been in this process in the past 10 weeks. So we're really just at the beginning stage of getting that data. And what we're trying to do is capture on a daily basis every transfer that happens. So if that's during the night, we're not going to ask the parents to do that QR code overnight. We're going to wait till the next day when they're settled into Ward 20. We'll either go around and speak to them, myself or some of the improvement team that's involved, or the staff nurses that are on shift, and we'll ask them their opinions then. And sorry, Tim, what was the second part of that?
The second part was whether or not you use this when transferring children to tertiary centres.
So
parts
no.
of it.
No, we haven't, but that is a good suggestion. It's something we look at. So we've got a separate transfer document for our out of hospital transfers. But yeah, potentially that is a good point of view, yeah.
Mm-hmm. And I suppose what you just said about over 2,000 transfers a year, you know, if you're capturing parental concern, that's an extra 2,000 times a year that you're checking in with parents and sort of hopefully doing that listening to what their concerns are and acting on them. Really good. The next question is whether or not you or how you involve sort of parents in the handovers and if you involve the child as well.
Yeah, so I don't think it was captured there on my slides, but some of the feedback has been from patients as well.
Yeah.
That tends to be more from the verbal feedback. But obviously we are looking at, we've got UNCRC in place, so we are looking at ways that we can capture the child's voice at the minute.
Yeah. And the other question from Helen there is whether or not you can share the questions from your QR code. I think we had a discussion about sharing your QR code, and if we share that, then you know we might open it up to people who aren't parents submitting or aren't involved in your ward. But would it be possible to get your questions that you ask the parents and share them with Helen?
Yep. Yeah, I'm happy to share them. It's great. Something again that we're looking at. So given the feedback that we've got already, you know, you start something and you think you're asking good questions, but when you get the feedback, it's not, we want to know why. They're answering no on the escalation, but they're not telling us why their concerns haven't been escalated or what's made them think that. So we need to have a look again at our questions and kind of refine them a wee bit. But yeah, happy to share what we've got just now.
Excellent. And I've got a question from Jackie Welsh in Ayrshire and Aaron as well, just asking if you engaged parents and carers before starting the journey that you're on now?
No, we didn't. So, and that, just be honest. So we started, initially I've started this project as actually as looking at a safe transfer. But when we looked at the safe transfer, so initially we were very focused on the SBAR document, and it was really about improving that handover document. But as you know, when you start a quality improvement project, you always end up with a million more. So since we've started looking at that, we were looking at how we could audit our document, and we thought about what makes a safe transfer. So part of that conversation come up is actually it's not just about the staff signing the document. It's not about them ticking the boxes. It's about, does the parent and the child feel safe? Do they feel that that they're involved in that process? And actually that work has then led on to a bit more of this. So initially, no, we didn't start out doing that, but I think the work that we're doing is really going to, hopefully we'll get feedback from parents that's going to steer that.
And that's totally how quality improvement works. You'll sometimes start out with one idea and you learn through understanding your system that there's other work to be done that maybe takes priority. So it's never too late to do engagement work as well. If you want to gather the views of parents, carers, children as well, it's never late to do that. So never too late to do that. So really good points there, Annie. Thank you. I'll pass back over to you, Sonia, to see if there's any calls or questions from the crowd.
Great, thank you. Helen, you did have your hand up. Did you want to come in with a question?
Yeah, it was just as a backup. I think it was me that asked the question about asked all the questions, I think. Sorry, I had a whole list that I was writing as you were talking. A great presentation. Thanks very much. Really thought-provoking. So they were rolling off my pen as I was thinking when you were speaking. But your questions. So I'm interested to see what the questions were, because we do it, but we do it very simply and say what went well. Not about transfer, just about care in general. What went well, what didn't go so well. And we've had themes, and it's quite informative and it's quite powerful, but perhaps we're needing to maybe expand it a bit, I don't know. But our model isn't, we don't have an assessment unit, our model is the kids all come into the ward. So that's why I was asking the question too about, do you do it for transfer out to tertiary, because we do something different, but really informative. Thanks very much, and great work, and you were really honest for all the hiccups you found and all the speed bumps. So it's quite good to hear that.
I think that for me, Annie, is also the most powerful thing. Is like, and that's what's fantastic about the fact that we all work in Scotland and we're all really honest about where we are and what we've learned, because actually you guys have gone through some challenging work. You've asked a lot of really important questions and gone, where are we now culturally? Where are we now staff-wise, etc., education-wise? Those are all really tough questions to ask, especially when most people have got, low workforce and high rates of sickness. And then there's also high numbers of patient demand. So it's fantastic that you've done that. I was going to use chair's privilege and ask you a question, Annie, sorry. But you just thinking about what Jess said around the fact that when she's been doing the research with her clinical teams in New Zealand and asking families, what's quite clear is that the staff are listening and providing reassurance to parents. But what the parents seem to be saying is, I don't just want some kind, calming words. I want you to do something. And I noticed that on that sheet that you showed us with the boxes about, did the parent have any concerns? If so, yes, and then at the bottom it says provided reassurance. I wonder whether it's something around what action was taken should also be included in that, or provided in your documentation somewhere. And I don't know what your reflections were of what Jess said and your thoughts, just hearing from your other colleagues' questions just now.
Yeah, I definitely think that has given me some food for thought as well. And Jessie's presentation was great. Definitely going to be stealing some of the ideas as well.
Learning, Annie, we're learning.
Yes. But yeah, I think on reflection and from talking to parents more, that the concerns that they've got, yeah, they do want action, they want something to be documented, and it really, we probably need to look at next, what is that process going to be if parents raise concerns? And I think there is a massive workload around staff as well in education. So just this morning, actually, I've just reviewed all my data and my run charts, and we are heading towards a bit of a dip just now, and I think that is about we need to go back to basics, and we need to go back to staff and educate them on communication and what parents are bringing up. And I think they need to now be fed back the feedback that we're hearing from parents.
Yeah, and I think there will be, that's the power of it, isn't it? It's that you said, we did, and this is now, and then we're going to revisit again, and this is what we're going to do. It's so much better to be in the space of listening and doing, rather than where you sometimes feel paralyzed by the enormity of everything that you have to do. But it's that one small step and asking each other, isn't it, and connecting. So that's fantastic. You're actually so advanced, we're ahead of time, so I can't see any further questions on the chat, or if there's any other opportunities or to ask a question. So is that okay, Tim, if we move on? Yeah, Annie, did you want to ask any questions or for anything specific of the group? You've got lots of expertise in the call. Are you happy with where you are?
No, I probably just need a wee minute to review all the comments. I've not had a wee chance to look yet.
We'll give you a summary of all of that, and it's lovely to see the comments from Elaine Anderson. There's lots of support and for your team, and lots of recognition for your whole team about everything that you've done. So well done, and thanks so much for sharing. As part of this SPSP programme, we are visiting every single board, and we're aiming to have a face-to-face visit and alongside it with a follow-up virtual visit. So I can't wait to reconnect with your team and see how far you've gone down the line with this project. It's fantastic.